Hello and welcome to the PowerPoint presentation for heart failure. By the end of this presentation, you should be able to understand and compare and contrast the pathophysiology for systolic and diastolic heart failure, right heart failure, left heart failure. You should be able to relate the compensatory mechanisms to the development of acute decompensated heart failure and chronic heart failure. You should be able to talk about the collaborative nursing care. You should be able to talk about interventions, assessment planning, the nursing process, and you should be able to describe the indications for cardiac transplant and nursing management of the transplant patient. We're going to go and do a quick review of normal physiology. If you don't remember this, please go get your anatomy and physiology book out and review. I'm going to trace a drop of blood entering into the right side of the heart, entering from the body via the vena cava into the right atrium. From the right atrium, it's going to move through the tricuspid valve into the right ventricle. From the right ventricle, it moves out into the pulmonary vascular bed, picks up oxygen, and moves back into the left atrium, from the left atrium into the left ventricle, and from the left ventricle out to the aorta, and then the aorta circulates oxygen-rich blood and nutrients to the rest of the body. Let's spend a second or two to review some basic cardiac terminology that you should remember. I first want to look at the word preload. Preload is the amount of pressure in the ventricles at the end of diastole. In other words, it's the amount of stretch or the amount of blood, the volume of blood, and the pressure that that volume creates inside the ventricles at the end of diastole or the end of filling. It is affected by the amount of blood that returns to the heart. So preload could be decreased when we have things like hemorrhage, dehydration, the use of diuretics, when we have fluid moving out of the vascular space into the interstitial space. Anything that would cause vasodilation or perhaps even the heart rate increasing so fast that we didn't have enough time for filling. They would all decrease preload. What increases preload? Preload is increased by anything that will affect the amount of blood that's returning to the heart. So something like heart failure will increase preload. Kidney disease will increase preload. An IV that dumps can increase preload. So anything that increases the volume of blood or the amount of stretch and pressure inside the ventricle at the end of diastole affects preload. Let's look at afterload. Afterload is either, you can replace those words with systemic vascular resistance or pulmonary vascular resistance. So it's the amount of resistance or the amount of pressure that the ventricle has to overcome in order to eject the blood from the left side of the heart into the aorta, or to eject the blood from the right side of the heart into the pulmonary vascular bed. When we increase afterload, we increase the workload of the heart, or in other words, we increase the oxygen demand of the heart, or how much oxygen the heart needs to do its job. Okay. Next, let's take a look at that last one there, contractility. Contractility refers to the force of the contraction. It's controlled by the sympathetic nervous system. It is enhanced. We can increase contractility by giving certain drugs like digoxin, dopamine, dobutamine. And it is decreased when there's hypoxemia, acidosis, or we're giving meds such as a beta blocker. So contractility is controlled by the sympathetic nervous system. When we have an increase in sympathetic activity, we have an increase in contractility. When we have an increase in the parasympathetic nervous system, we have a decrease in contractility. All right, then the last one on this slide is cardiac output. And we remember that cardiac output is heart rate times stroke volume. So cardiac output is the amount of blood that the body needs to meet the oxygen and nutrient demands of the tissues. We measure cardiac output, so anything that's going to affect heart rate or anything that's going to affect stroke volume is going to affect cardiac output. We know that the heart rate is controlled by the sympathetic nervous system, and we know that stroke volume is affected by preload, afterload, and contractility. We can measure cardiac output by measuring mean arterial pressure. Mean arterial pressure, different sources will say it different ways, but for us, we're going to say that a normal mean arterial pressure is between 70 and 110. But what we do know is that anything less than 60 millimeters of mercury is going to create a situation for inadequate perfusion. When we are talking about cardiac output, we can measure it as in terms of MAP. We can also measure it directly through something that they call the ejection fraction. The ejection fraction is the percent of end diastolic volume that's ejected with each contraction. So normally we eject 55 to 65%. Somebody who has heart failure has an ejection fraction of less than 40%. Well, the last one there, we talk about cardiac reserve, and that is the body's ability to maintain homeostasis, to adjust the heart rate and stroke volume for various situations, for exercise, for rest, for different things like that. Okay, what things affect the heart rate and blood pressure? Well, the autonomic nervous system. If you are not very familiar with the autonomic nervous system and how it works and the neurotransmitters and the receptors, alpha and beta receptors, then you need to go to your physiology book and look that up. Your Lewis book also does a very nice job at explaining it. But you need to know this like the back of your hand in order to get this course. Okay, so the autonomic nervous system. The sympathetic nervous system is mediated by the catecholamines, specifically epinephrine and norepinephrine. It is regulated by the baroreceptors and chemoreceptors. And what does it do? When the receptors are stimulated, the alpha and beta receptors, we increase the speed of conduction through the SA node. We increase contractility, and we cause vasoconstriction. Also, to a lesser extent, the sympathetic nervous system promotes the release of renin, which we're going to talk about in a little bit. So, how do the baroreceptors work? How do the chemoreceptors work? Where are they? The baroreceptors are in the arch of the aorta. They're sensitive to the amount of stretch or to blood pressure inside of the aorta. And when there's too much pressure or too much stretch, those baroreceptors send a message to your vasomotor center that says decreased sympathetic activity and and increased parasympathetic activity. When pressure is too low, a message goes that says increased sympathetic activity. So this is how we keep blood pressure in check. Now, chemoreceptors, they respond to the partial pressure of oxygen and the amount of carbon dioxide. So they're chemical sensors in the body. And also they respond to acidosis, acidotic states. And when CO2 is high and there is acidosis, The chemoreceptors send a message to the vasomotor center in your brain that says increase sympathetic activity and increase heart rate. That way we'll increase perfusion. Okay, heart failure. Heart failure affects 6 million people worldwide. 550,000 people a year die. 20% who get it will die within the first year, 50% within 5 years, and it costs billions and billions of dollars to care for it. It is the #1 cardiac problem worldwide. What is it? It is a syndrome characterized by signs and symptoms of fluid volume overload or fluid volume excess and a decrease in tissue perfusion. It is the inability of the heart to pump enough blood to meet the oxygen and nutrient demands of the body. The pump, your cardiac pump, the heart, its job is to pump blood. Its job is to pump blood so that the tissues of the body can get the oxygen and nutrients that they need. If the pump is broken, if the pump is inadequate, then we have heart failure. It is a chronic, progressive disorder. It does not go away. Once you have it, you have it. How do we get heart failure? Well, we said that it is a progressive process. We know that there are many things that cause it, but it starts with one incident, one initiating event. It's any event or thing that would impair cardiac function, like an MI. Anything that causes an increased workload of the heart, like hypertension, coronary artery disease, valve disorders, renal dysfunction, fluid volume overload. So when we list cast of characters there, coronary artery disease causes myocardial dysfunction because it deprives the heart cells of oxygen and causes cellular changes and impairs the pumping action of the heart. Coronary artery disease is 60% of people with heart failure have coronary artery disease. Then we have an MI down there. This is heart necrosis. So we have that cellular death. We have an area of the heart that's injured. We have a decreased contractility. We have decreased pumping action, failure of the muscle. Systemic or pulmonary hypertension increase afterload. And when you increase afterload, you increase the load of the heart. You decrease the oxygen demand of the heart. So the heart ends up with some hypertrophy and impaired filling. Then we have valvular disorders. We are supposed to talk about this a little later in the semester, but we're going to talk about valves. We're supposed to have one-way forward flow in the heart. The blood's always supposed to go right atrium, right ventricle, to the lungs, to the left atrium, left ventricle, and out to the body, and it keeps doing that. And if I have a valve disorder, sometimes I get backward flow, and that's a problem. And then we have that cardiorenal syndrome. If you have heart failure, most likely you're going to have kidney failure. If you have kidney failure, most likely you are going to have heart failure. And then that last category, other things, be things like increased metabolic rate when we have hyperthyroidism, hypoxia, anemia. These will also increase the workload of the heart. Heart failure is the inability of the heart to pump enough blood to meet the oxygen and nutrient demands of the tissues. We said that the #1 cause of heart failure is coronary artery disease. And the reason that coronary artery disease causes heart failure is because it increases afterload. It increases systemic vascular resistance. It increases the amount of work, the amount of pressure that the heart has to overcome in order to get the blood out of the ventricle and into the aorta. And when it gets in the aorta, then it can perfuse. So when we have heart failure, the pump is failing because it's worked too hard. So if the pump is working too hard to overcome that vascular resistance, we increase oxygen demand. We increase the workload of the heart. We increase how much pressure the heart has to overcome. And over time, the heart becomes less and less able to overcome that pressure because the workload was high and the force of left ventricular contraction has to be so much that the oxygen demand is high. And when the heart fails and doesn't meet the oxygen demands of its tissues, we have left ventricular hypoxia. And when I say the word left ventricular hypoxia, you should be thinking, wow, hypoxia is causing tissue injury. And as we continue to have more and more and more tissue injury, we impair the force of contraction. And as I impair the force of contraction, my muscle is getting weak. And I have an inability to pump the blood out even more. I'm not having trouble overcoming that. And so I have a decrease in cardiac output. And decreased cardiac output really refers to poor tissue perfusion. Now, we could have that coronary artery disease and the heart could overcome it because the heart is a muscle, and like any muscle, it can get bigger and stronger. But as it gets bigger and stronger, it'll change shape. So it does initially get bigger and stronger, and by increasing the workload, by increasing the force of contraction, it's able to maintain cardiac output. But eventually, that ventricle gets so big and thick, it has left ventricular hypertrophy. And the body likes to maintain homeostasis. So the first thing that it did when we had this coronary artery disease that was affecting the amount of cardiac output, the first thing the heart did was say, okay, I'm going to increase the force of contraction. And that was pretty good because it worked for a while. It worked for a while until the muscle got too big and thick, and then it was actually a detriment. And the body also has other things that it does. The second that there is a decrease in cardiac output, we know that the body's going to try to do things to overcome. So when cardiac output is inadequate to meet the metabolic demands of the body, these compensatory mechanisms that we're going to talk about, they kick in. And initially, they improve cardiac output, but eventually they have a damaging effect on the cardiac pump, similar to the hypertrophy. So let's talk these, they call it neurohormonal compensation. Okay, so let's talk about the sympathetic nervous system. Well, we said the sympathetic nervous system is mediated by the catecholamines epinephrine and norepinephrine. And it is regulated by these baroreceptors that are located in the arch of the aorta. And when there isn't enough stretch or there isn't enough blood rushing past or cardiac output is inadequate, the baroreceptors will send a message to the vasomotor center in the brain, and the vasomotor center in the brain will increase the sympathetic nervous system. And when we talk about increased sympathetic nervous system, we say that we will increase heart rate and increase blood pressure. Okay, so we know that cardiac output is heart rate times stroke volume equals cardiac output. So here we're saying that because of this coronary artery disease, our heart was having a hard time overcoming it. and we had a decrease in cardiac output, so we will increase heart rate. And in the beginning, increasing heart rate, stroke, will help to improve cardiac output. It will also increase the contractility of the heart. So it will say to the heart, work a little harder. And in the beginning, these are good compensatory mechanisms. These are people who are walking around and they have beginning signs of heart failure, but they don't know it yet because their body is compensating. So far, they had the heart was working harder and squeezing. We have increased the heart rate. We have increased the contractility. And the sympathetic nervous system also vasoconstricts. And this, under normal conditions, this will improve the amount of blood flow back to the heart. It will increase preload. And if it increases preload, it increases, another way to say that is it increases stroke volume. So as a compensatory mechanism, the muscle is failing, but it is increased contractility, it's increased the heart rate, and it's increased afterload. It's caused vasoconstriction. All of those things are good initially. They work initially, but they're hurting the heart because every time you increase the workload of the heart by making it beat faster, by making it contract harder, by making it overcome more vascular resistance, we're doing more damage. We're increasing the workload on the heart, causing more hypoxia. And when I cause more hypoxia, I cause more tissue injury. Next thing. Now, the sympathetic nervous system is the thing that kicks in first. It has very little effect, but it kicks in first. Then we're going to move to the renin-angiotensin-aldosterone system. The kidney is the major regulator of blood pressure. And when the kidney is not being perfused properly because the cardiac muscle is weak, the kidney says, oh, I have to increase perfusion. And the way it normally does that is to initiate the renin-angiotensin-aldosterone cascade. So the kidney will release renin. Renin will go to the liver and convert angiotensin to angiotensin 1. Angiotensin 1 is a vasodilator. Angiotensin 1 will meet with angiotensin converting enzyme in the lung. Angiotensin converting enzyme will convert from angiotensin 1 to angiotensin 2. Angiotensin 2 is a very powerful vasoconstrictor, so it will make my vessels smaller. The idea is that it will increase perfusion to the kidney and it will increase the amount of blood returning to the heart, or it will increase stroke volume. In addition to that, angiotensin 2, we recall, is going to increase aldosterone levels. And when we increase aldosterone levels, we are going to hold on to sodium and water, which will increase my volume. If I increase my volume, I will increase the amount of preload or the amount of blood returning to the heart. And if I can increase stroke volume, at least temporarily, it will improve cardiac output. The last thing that I want to say that the renin-angiotensin-aldosterone system does is that it is going to ask the endothelium, the endothelial lining of the vessels, to release endothelin, which we know is a vasoconstrictor as well. Oh, and the one thing I didn't say about the sympathetic nervous system is that to a much lesser extent than the renin-angiotensin-aldosterone system, but the sympathetic nervous system asks the kidney to release a little renin to start that whole cascade. So we have the sympathetic nervous system, very good in the beginning, but increases the workload of the heart. We have the renin-angiotensin-aldosterone system, very good in the beginning because it's going to increase preload, it's going to increase stroke volume, but as it does that, it increases the workload of the heart. Now the heart's pumping more blood and it's pumping against more force. Then we have ADH. ADH, antidiuretic hormone released from the posterior pituitary in response to poor cerebral perfusion. So when we have ADH, we are going to increase water retention, right, distal convoluted tubule of the nephron. We are going to increase the amount of water that is held onto or that we reabsorb, and that is going to increase volume. And when we increase volume, that increases preload and stroke volume, which will improve cardiac output. ADH also stimulates the release of the endothelin, and the endothelin is a powerful vasoconstrictor. It works opposite of nitric oxide. Remember that all those compensatory mechanisms are very good things in the beginning. And in the beginning, they work to maintain cardiac output. Even though they're increasing preload and they're increasing afterload, which is actually increasing the workload of the heart, in the beginning, for some time, that's the body's attempt to maintain homeostasis, and it works well. But over time, the workload of the heart has been so much, the oxygen demand is so much, resulting in the hypoxia, and the hypoxia results in more tissue damage, and then the muscle gets weaker and weaker. And eventually, we said, we have this increase in volume because of ADH and because of angiotensin II and the aldosterone, and we get a lot of stretch. The heart is unable to handle this extra blood, and we get a lot of stretch in the atria and the ventricles, and we produce this stuff called ANP and BNP. ANP comes from the atria, BNP comes from the ventricle, and what does it do? It increases glomerular filtration rate and diuresis. So it increases the amount of water, and it's called nature's diuretic. Helps to excrete water, helps to excrete sodium. They vasodilate, which will decrease blood pressure. They inhibit renin and aldosterone, and they interfere with ADH. They try and counteract all of the sympathetic nervous system and RIAAs and the renin-angiotensin aldosterone system. We also start to release nitric oxide. Nitric oxide works opposite of the endothelin. It is released from the endothelium. It is a vasodilator. It decreases blood pressure. In other words, it decreases afterload. And we know that nitric oxide has an inverse relationship to angiotensin II. There are many different kinds of heart failure. I'm going to run through them on this slide very quickly, and then we're going to take a look at them individually. I'm going to start with the most common type of heart failure, and that is left-sided heart failure. Here's its definition. It's an inability of the left ventricle to pump enough blood, causing the blood to back up into the lungs. I'll say it again. An inability of the left ventricle to pump enough blood, causing blood to back up into the lungs. It can be acute or chronic. It can be mild or severe. There are two types of left-sided heart failure. There can be systolic heart failure or diastolic left-sided heart failure. And so when we talk about systolic heart failure, that's a pumping problem. That is an inability of the heart to contract enough to provide blood flow, forward blood flow. They call it forward failure. Most cases of heart failure are left-sided systolic heart failure. That means that the pump can't pump. It can't pump enough blood to move the blood forward. Forward means out of the left ventricle and into the aorta. It's characterized by ejection fraction of less than 40%. Then there is the diastolic left-sided heart failure, they call it diastolic failure. It's a filling problem. The heart becomes stiff. It's an inability of the left ventricle to relax normally, resulting in fluid that backs up in the lungs. Essentially, it's high filling pressures related to a non-compliant ventricle. And so you can say that, wow, that person who has left ventricular hypertrophy, it's non-compliant. It doesn't move, it doesn't stretch, it doesn't squeeze. They might have high filling pressures, and those high filling pressures cause the blood to back up and to back up into the lungs. Okay, let's take a look at right-sided failure. Right-sided failure is ineffective pumping of the right side of the heart. The right ventricle is not able to pump the blood into the lungs. So we cause congestion in the abdomen, in the legs, in the feet, so it backs up. And then there's another thing on here called acute decompensated heart failure that you'll see. And acute compensated heart failure means we have all those compensatory mechanisms in place and the body's trying to compensate. And then when we recognize that the person has heart failure, we jump in and we give them medicine and we control them with diet and all kinds of special things. And they're able to go along and they have chronic heart failure. It's there, but we're able to deal with it. We're able to make sure that their tissues are being perfused and their oxygen saturation is okay, that they have a quality of life. But at some point, something happens. There's an insult, which we'll talk about in a little bit, which causes them to compensate. That means that they have all the terrible signs and symptoms, and their body is not able to compensate, and so they're showing signs, very poor signs of heart failure. Let's dive into left-sided heart failure a little more and think about it. So we know the very first thing we did was trace a drop of blood. We know that the heart's job is to create forward flow. That means the left side of the heart, the blood comes from the lungs into the left atrium, from the left atrium into the left ventricle, then the left ventricle pumps it out to the body. When the left ventricle fails, when the left ventricle is not able to pump the blood out of the ventricle into the aorta, the blood backs up because it's piling in, right? The right side of the heart is still pumping. The left ventricle is not doing its work, so the blood will back up from the left ventricle. It will back up into the left atrium. And when it backs up into the left atrium, that cup will get big and swollen and overflowing, and the blood will back up into the lungs. And when it backs up into the lungs, I get pulmonary congestion. And we say that you cannot have one-sided heart failure without soon getting the other. Because we have left-sided heart failure, the left ventricle, because it fails to pump or because it can't fill up enough with systolic versus diastolic. And so the blood backs up from the left ventricle into the left atrium and from the left atrium into the lungs. And when it's in the lungs, it's really where it is, it's in the capillary beds. And those capillary beds get big and full and swollen. And when they're big and full and swollen, it becomes, we say that the pulmonary vascular pressure is very, very high, and it's hard for the right side of the heart to pump. And when it's hard for the right side of the heart to pump, then soon the right side of the heart will fail. So, left-sided failure means that the ventricle has an inability to pump the blood forward. It's not able to get the blood out of an adequate amount of blood out of the left ventricle and into the body. And so the blood backs up into the lungs, and it causes. So when we talk about clinical manifestations of left-sided heart failure, we are thinking about Signs and symptoms related to pulmonary congestion, because the blood has backed up from the left atrium into the lungs. And when it backs up into the lungs, we are going to see dyspnea, dyspnea on exertion, exercise intolerance, orthopnea. Orthopnea is feeling like you can't breathe when you lay back, when you lay flat. First, there will be some crackles in the lungs. There will be a cough. First, just a dry hacking cough, then some white froth, and then some blood-tinged sputum. There might be some wheezing in there because the lungs are congested, causing some pressure on the bronchial tubes. We will see a decrease in the O2 sat and the use of accessory muscles. And then because we have poor forward flow, that means that the left ventricle was not able to pump blood out to the body. We have signs and symptoms of poor tissue perfusion. Of course, that would be our O2 sat being down. Then we're going to look at a decrease in urinary output, because that's often one of the first things that we see is poor perfusion to the kidney, which decreases the glomerular filtration rate, which results in a decrease in urinary output. We might even see an increase in urination throughout the course of the night, like when the person lays down and the kidney is being better perfused, we have some more dilute urine through the night. Altered digestion or nausea and anorexia related to the increase in or the decrease in perfusion to the gut. Some dizziness or lightheadedness, changes in mental status, restlessness, agitation, confusion, cool, clammy skin, tachycardia, because the compensatory mechanisms are going to be kicking in. Maybe even a little bit of low blood pressure. Okay, well, we said when we have left-sided failure, that's going to create an increase in pulmonary vascular resistance, or the afterload of the right side of the heart. And when we have that extra pressure that the right side of the heart has to overcome, soon the right side of the heart will fail. And when the right side of the heart fails, that means that the right side of the heart is not able to pump the blood forward. It's not able to pump the blood into that very high pressure system that the left side of the heart has caused. So we say that the #1 cause of right-sided heart failure is left-sided heart failure. And we have poor forward flow, and so then the blood backs up, and the blood backs up in from the right atrium, or from the right ventricle to the right atrium, and from the right atrium back into the body. And so we're going to see all that peripheral edema and venous congestion, hepatosplenomegaly, JVD. You know, we'll have that, the liver will be full, you know, the hepatosplenomegaly, all that extra pressure, and portal hypertension. And eventually that portal hypertension can lead to ascites and abdominal fullness. So, then we talk about this condition called cor pulmonale. So, cor pulmonale is right-sided heart failure from right ventricular infarction or pulmonary embolism, most often pulmonary hypertension, like with COPD. So, cor pulmonale is a special word. Often it's heart disease that comes from a pulmonary problem, and there becomes super high pressure in the pulmonary vascular bed, and it becomes very hard for the right side of the heart to pump. And when the right side of the heart fails, then the blood backs up into the venous system like we talked about. So specifically, the most common cause of cor pulmonale is COPD. So let's look at how it works. We're going to deviate just a little bit because this is another little topic area, a subset of this, but it is heart failure, just caused by something different. So let's talk about how COPD can give you cor pulmonale or right-sided heart failure. It's all about vasoconstriction. In all cases, hypoxia, hypercapnia, that means too much CO2, and acidosis cause vasoconstriction in the pulmonary vascular bed. So it doesn't matter what your problem is. So every single time there's hypoxia, hypercapnia, or acidosis, there is vasoconstriction in the pulmonary capillary beds. And in COPD, areas of the lung become hypoxic and there is vasoconstriction in that area. And under normal conditions, that's okay, under normal circumstances, because if I have COPD and I have a diseased area of my lung, or I have pneumonia and I have a actively ill part of my lung, and that is resulting in hypoxia, we get vasoconstriction, and normally the blood then is shunted from there to more functional areas of the lung. But when you have advanced COPD, there's disease everywhere in your lung, and as a result, there is widespread, very diffuse, increased pulmonary vascular resistance. And that increase in pulmonary vascular resistance increases the workload of the right ventricle. Then the right ventricle gets hypertrophy, and that hypertrophy leads to heart failure. We talked a little bit about the signs and symptoms. So here I've listed them for you. What I didn't talk about when we were talking about right-sided failure is this S3 and S4 sound, particularly the characteristic S3, or they call it a gallop. So we normally have S1 and 2, the lub and the dub, and when we get this additional sound, extra sound in there, we call it an S3, which is often one of the very first signs of heart failure, and that is telling us that there's some extra volume in there. So that's a classic symptom that I think you would want to remember. Then we have a lot of those abdominal signs and symptoms, bloating and ascites, often nausea and anorexia because of the extra pressure in there. Noteworthy about the edema, so we said we will increase in blood pressure and increase in weight gain, dependent edema. So if you're walking around, it might be in your hands or feet. If you are on bed rest, it might be in your sacrum. And then the last thing worth mentioning here is this paroxysmal nocturnal dyspnea, PND. What that is happens several hours after a person goes to sleep, and the person will wake up suddenly feeling like they're being smothered and they can't breathe. And basically it's a shift of fluid from, you had edema all day, and it's a shift of fluid back into your vascular space, and it just kind of overwhelms your pulmonary system. All that person needs to do is sit up, if they're capable, to get up and take a walk, and that usually resolves the problem. I want to spend a second and talk about the difference between altered tissue perfusion and fluid volume overload, fluid status. This slide is very important. When we are talking about altered tissue perfusion means not enough oxygen and nutrients, not enough oxygen getting to the tissues. When there's not enough oxygen that gets to the tissues begin to experience hypoxia, they begin to be damaged, and as the tissues are damaged, the organs begin to fail because they're unable to carry out their normal function. We're going to talk about in the next slide acute decompensated heart failure. But when we're talking about poor perfusion, signs and symptoms of not enough oxygen to the tissues, restlessness, agitation, confusion. Why? Because they're not getting enough oxygen to the brain, not getting enough oxygen to the skin, cool and clammy, decreased urinary output, decreased O2 saturation. They might be cyanotic. They might experience chest pain or shortness of breath. They might even have changes in BUN, creatinine, GFR, bilirubin could be elevated. When we're talking about fluid status, certainly the amount of fluid on board affects tissue perfusion because it can cause the heart to be overwhelmed and have heart failure. We might not have enough fluid on board and we have low blood pressure and risk of shock. But in this case, we're talking about how much fluid is inside the vascular space, inside the interstitial space. So when we talk about fluid status, we talk about weight and blood pressure. We're talking about edema and pulmonary congestion, JVD, ascites, all these things. But when we measure fluid status, weight and blood pressure are a much better indicator than edema or some of those other signs and symptoms. We said that when a person develops a heart failure, it's a slow, progressive onset, usually, unless it's because of a severe acute MI. And the body does a really good with the compensatory mechanisms, a really good job at keeping them in a state of homeostasis. But we know that those compensatory mechanisms are actually making the failing myocardium work much, much harder. And it can result in a major complication called acute decompensated heart failure, which is a sudden onset of symptoms. Usually comes from the left ventricle. The left ventricle fails to pump blood forward, and then that blood just backs up into the lungs, and they get a life-threatening pulmonary edema. And we see an increase in all of those signs and symptoms that we said. We have a poor cardiac output and poor perfusion. It is an emergency. It does require immediate treatment. And as an astute nurse, you might pick up early signs, which would be an increase in respiratory rate, maybe a restlessness, agitation, a confusion, maybe a decrease in the O2 sat, but then later, and can happen very, very quickly, from you feel just fine to, oh my goodness, to tachycardia. Okay, pulmonary edema. So the left side of the heart was not working, and the blood backed up into the lungs. And when it backed up into the lungs, it was in the capillaries. And we know that these capillaries, you see this picture, we know that those capillaries surround or lay on the surface of the alveoli. And the air comes down, the oxygen comes down in the alveoli, moves across a little interstitial space, and then it diffuses into the capillaries. And those capillaries then take the oxygen and transport it to the rest of the body via the circulatory system. When the blood backs up from the left atrium into the lungs, the pressure inside those capillaries becomes so high. The hydrostatic pressure, the pressure from the extra fluid. And the fluid then moves out of those capillaries across the interstitial space and through the interstitial space, and it fills those alveoli up. And as those alveoli fill up, we are not doing gas exchange, and we have acute pulmonary edema resulting in poor tissue perfusion. Acute decompensated heart failure is an emergency. It needs immediate intervention, and you're keeping the ABCs in mind: airway, breathing, circulation. immediately, what are you going to do? You're going to sit the person up. You're going to sit them in high Fowler's position. You're going to put pillows under their arms so that to allow for maximum chest excursion. You're going to put on high flow oxygen, 5 or 6 liters, usually via mask. And you want to keep their O2 sat, depends on what source you're looking at, between greater than 90, and some sources say 92. It is very important that we address this respiratory distress. Sometimes the person's going to need CPAP or BiPAP or maybe even intubation and ventilator. Because remember, as they have the hypoxia, as they have this pulmonary edema, they are having an elevation in CO2. They call that hypercapnia. And remember I said to you, when someone has hypercapnia, it is leading to acidosis, respiratory acidosis. That will increase pulmonary vascular resistance. It will cause the blood vessels in the lungs to vasoconstrict. So this is a major emergency. We are giving diuretics, usually high doses of IV Lasix, to quickly diurese them. We are concerned about circulation. So we are giving these people ionotropic drugs that to increase contractility and decrease afterload. Something maybe like dopamine. We can use that continuously because it increases contractility, but maybe even dobutamine or milrinone will increase contractility and cause vasodilation. When we are giving drugs like dobutamine or milrinone, we are usually using a pulmonary artery catheter to measure pressures and very high-tech invasive hemodynamic monitoring. We can try things for comfort for these patients. Morphine will be very helpful because it will reduce preload and afterload. It dilates the pulmonary arteries and blood vessels, and it decreases myocardial oxygen demand. So that's a great one. We already talked about positioning, reassuring these people, managing external stimuli, not 50 guests in there, TV on, people in and out. You want to reduce the stimuli to decrease oxygen demand for these people. Oh, back to the medicine. So we talk about ionotropes and vasodilators. We can also talk about drugs like nitroprusside is a vasodilator, a coronary artery vasodilator. That's given as a continuous drip because we're trying to avoid a cardiogenic shock or a hypertensive emergency. We're given drugs to optimize heart rate and rhythm. We don't want it too fast because if it's going too fast, the heart can't fill and it leads to ischemia. And we don't want it going too slow because if it's going too slow, heart rate times stroke volume equals cardiac output. So we'll see these patients on ACE inhibitors and beta blockers as well. Other complications that we need to talk about, a pleural effusion. We said that pressure, an increase in pressure in the pleural capillaries causes a movement of fluid into the pleural space, right? I showed you that pulmonary edema and how the fluid moves into the alveoli. It can also move into the pleural space. And when it moves into the pleural space, I'm concerned about cardiac tamponade. I'm concerned that that fluid that's in that pleural space will actually press on the heart and impair its pumping action and particularly the left ventricle's ability to pump the blood into the rest of the body. Cardiac dysrhythmias are another are another problem. We are concerned that the heart enlargement and the ischemia to the lung, so all those changes in shape and the remodeling causes chaotic firing, and the most common dysrhythmia is AFib, and we know that with AFib we are concerned about a left ventricular thrombus that can cause MIPE or stroke. Then we talk about hepatosplenomegaly, hepatomegaly specifically. We have that right ventricular failure, and the right ventricle backs the blood up into the body, and then we get liver congestion. And when we get that liver congestion or a lot of blood in the liver, it causes death to the cells. The death to the cells causes fibrosis, and the fibrosis leads to cirrhosis. We call that cardiac cirrhosis. Just put a little star here because you will do cardiac cirrhosis. You will do cirrhosis of the liver later in the semester. And of course, the last one is the renal failure. You heard me say that you rarely get renal failure without heart failure, and you rarely get heart failure without renal failure, because they kind of go hand in hand. With renal failure, which we're going to do also later in the semester, you'll see that there's a significant amount. Let's take a minute to review the diagnostic studies. First thing is a great history and physical. We really need to determine the underlying cause and the severity of the problem. So there's a lot of questions that need to be asked, and I'm just going to run down a couple for you. You're going to want to know, this is your subjective data from your patient. What brought you here? What brought you in? What made you seek medical care? Did these signs and symptoms begin suddenly, or did they worsen over time? Do you know if something makes those better or worse? Have you felt short of breath? Do you wake up in the night? Can you speak as much as you like before getting short of breath? Do you cough throughout the day, mostly in the morning? Do you use home oxygen? Have the symptoms kept you from sleeping? Do you sleep in a bed? Do you sleep in a chair? How many pillows do you need to use? Can you lay flat in bed? How many blocks can you walk without stopping? Can you climb stairs? Can you dress yourself without sitting down? Do you wake up at night and suddenly have to sit up to catch your breath? How far can you walk? There's just so many questions that you can ask, but you're getting at their level of activities of daily living. Okay, so let's take a look at some of the laboratory studies. Certainly everybody gets a CBC, and in that CBC, for general health, we also want to look at electrolytes in general. We want to do a BUN, creatinine, GFR. We want to make sure how their kidney is doing and how it's being perfused. We want to look at thyroid function to make sure that this heart failure is not related to a thyroid issue. We want to look at liver function to see if it's from portal hypertension. We certainly want to look at a lipid profile, all their cardiac markers to see if it's what kind of injury it is. We want to look at the BNP and the pro-BNP because this will tell us how long, how severe the heart failure is. Some hospitals are still using BNP, but most hospitals have transitioned to pro-BNP, which is a pro-hormone of the BNP. You remember I told you that the BNP was a hormone secreted by the ventricle in response to too much stretch. So the pro-BNP just kind of tells us how bad the signs and symptoms are, how severe it is. Chest x-ray will show us about the size of the heart, how much congestion. We certainly want to get an echocardiogram, either two-dimensional echo with Doppler flow is usually adequate, or maybe a TEE, transesophageal echocardiogram. That will tell us if there's any valve abnormalities down there. It will also be able to estimate the ejection fraction. You'll remember that heart failure, the ejection is less than 40. Normal is greater than 55. We're going to want to do ABGs and O2 saturation to see how this person is being perfused. We'll do an EKG. That really will only tell us about myocardial ischemia and any dysrhythmias that they have, not really and that they do have ventricular hypertrophy, but not really the extent of the heart failure. There's stress tests, of course, that can be done. And some of the diagnostic things that we're not really going to talk about here are the hemodynamic monitoring, the more invasive hemodynamic monitoring, things like pulmonary artery pressure and wedge pressure. You will be talking about these. You'll be talking about these later in the semester. You'll learn about those. So you'll just put it in your notes here, and you'll understand it at the end of the semester. Okay, our goal is to treat the underlying cause and any contributing factors. So here's the goals of all care. To decrease preload and decrease afterload and improve cardiac output. So in all instances, that is our main goal. The expected outcome is this is a star. You put a star next to this and write down exactly what I'm saying. The expected outcome. How do I evaluate the effectiveness of my care? The goal of my care is this: to increase cardiac output by improving stroke volume and heart rate. And stroke volume is determined by preload, afterload, and contractility. I'm going to say it again. Our goal is to increase cardiac output by improving stroke volume and heart rate. And stroke volume is to be determined by preload, afterload, and contractility. Our goal is to decrease preload, decrease afterload, and maximize contractility. We have some other less important. We want to improve left ventricular function and reverse any remodeling that was done. We certainly want to preserve target organs. That means anything that has, if we can correct the underlying tissue perfusion problems, we will fix the, make sure to protect the kidney and the liver, skin, gut. Improve the quality of life, have better choices, and we want to decrease lifestyle choices, and we want to decrease morbidity and mortality. First, we're going to look at the ABCs. We're going to look at oxygenation. We need to maintain O2 saturation. We'd like to have it greater than 92%. In acute decompensated heart failure, we'll take 90 to 92, 93. But for regular heart failure, we really want it to be greater than 92 or 93%. It depends on which source you're looking at, but really it matters about how symptomatic your patient is. So we're certainly going to be monitoring on a routine basis every Q2, Q4 hours. Remember, we want to have them in a high Fowler's position with their feet dangling. That way we can decrease venous return, keep the blood down in their feet and not up in their lungs. We're going to use anything that we need to do to reduce the work of breathing and their distress. So high flow oxygen, they might need BiPAP, they might need CPAP, they might need intubation. We want to keep the stimulation down in the room, right? We want to have rest. Morphine will decrease the workload. And then we have these things called circulatory support devices. And you will talk again about all of this stuff that I'm talking about here, you will talk about it towards the end of the semester as well. So I'm going to talk about an intra-aortic balloon pump. And this is to assist coronary blood flow to the cardiac muscle and to decrease the workload of the heart. So this is a device that the person would be in the intensive care unit and they would be being monitored. And this device is trying to improve blood flow back to their heart. So we have poor coronary perfusion and the workload of the heart is so high and the heart is failing. But in order to preserve its function, we need to get it oxygen. And so this intra-aortic balloon pump is something that we use, and again, at the end of the semester, you'll learn how to use it. But for now, you're going to say it will improve coronary blood flow and decrease the workload of the heart. And then we have this thing called a VAD, ventricular assistive device. And this is basically an external heart. It maintains the pumping action of the heart. It gets surgically implanted. It is battery operated. It's a mechanical pump. It is highly effective. It's not necessarily, people have them, but we say, in the books, they say that this VAD is to bridge to transplant. So then we have all kinds of different pacing options. We have this CRT that they do that is cardiac resynchronization therapy. They put a lead in both ventricles and they try and synchronize the beat because remember, dysrhythmia is common in heart failure. So it's basically a kind of a pacemaker-like thing. And one lead goes in both ventricles, and the goal is to improve cardiac output and decrease the workload. There are a lot of dysrhythmias, so the patient might need an ICD, an implantable cardioverter defibrillator is also a choice, so an ICD or something. Sometimes there's coronary bypass surgery that's needed, or percutaneous coronary interventions, like where they go in through the femoral artery, they drive up in there with the catheter and they blow up a balloon. Let's see what else. We have goals to increase vascular volume. That would be to decrease preload. That was one of our main goals. And they can do that with a process called ultrafiltration or aquapheresis, which is kind of like dialysis. This is treatment reserved for those that are unresponsive to diuretics. And essentially what it's going to do is filter their blood, filter the extra fluid out of their blood, which will decrease venous return and decrease preload. Okay, here you have it again. I'm going to say drug therapy is used to decrease preload and afterload, improve cardiac output, and manage the symptoms, the underlying symptoms. So one of the things that we can do is give diuretics. A diuretic will reduce the edema, but most importantly, it will reduce preload. We can give loop diuretics like furosemide. Less effective diuretic is a thiazide diuretic. And the least effective of these listed here is the aldosterone antagonist, the potassium-sparing diuretic. What's nice about this aldosterone potassium-sparing diuretic is it will block the neurohormonal effects of the aldosterone and excrete sodium and water. Remember that when we excrete sodium, sodium and potassium run opposite of each other, so we will hold on to potassium. The loop diuretics, we spill potassium. Some providers will give a potassium supplement. Others will use aldosterone or potassium-sparing diuretic to counteract it. But something that's very important for you to know is before you give diuretics, you must check the BUN, creatinine, GFR, and potassium. You cannot give a loop diuretic if the potassium is too low or if the kidney function is not working. You do not want to ever give a potassium supplement without checking the potassium level as well as kidney function. Remember this, that you are concerned about potassium in diuretics. If a creatinine is greater than 1.8, notify your healthcare provider before you give a potassium supplement. This will make more sense when we do kidney disease, but you'll know that kidney disease patients have high potassiums. So if you have a creatinine of 1.8, you're going to be concerned that you'll have too much potassium in there. Okay. We can also give drugs to improve the contractility of the heart and improve exercise tolerance. Some of these drugs that we give, called ionotropic drugs, like dobutamine, dopamine, milrinone, they're only given IV. You can give DIG, PO or IV. DIG is used a lot less now than it used to be. There's drugs called Natracor, Primacor, to decrease blood pressure and improve cardiac output. And we also give morphine because morphine will decrease afterload and decrease the oxygen demand. We said that most of the drugs that we give to interfere with the normal compensatory mechanisms, which make it very difficult for that failing heart to pump and actually do damage. So I'm going to review them here, but I would highly recommend that you go back to your pharmacology notes and review these drugs as well. Okay, so the ACE inhibitor, or the ARB, the angiotensin II receptor blocker, they are going to decrease blood pressure by blocking angiotensin II, and they will block angiotensin II, which will also increase block sodium and water resorption and decrease preload. So this drug is great. Everybody who has heart failure should be on an ACE inhibitor. It'll improve the symptoms and slow the progression of the disease. The beta blocker will interfere with the sympathetic nervous system activity. It will decrease blood pressure. It will decrease afterload. You use it cautiously because we are a little bit concerned because beta blockers will also decrease heart rate. So we want to make sure we don't decrease it too much to negatively impact on the cardiac output. Nitrates of vasodilators, they decrease preload and afterload. They are nitroglycerin, and apresyline, hydralazine, nitroprusside. That Bidil that you see listed there is a combination drugs that is used specifically for African American patients only. It's a combination of hydralazine and isosorbide. Okay, now what about teaching? What about nutrition? Well, diet is a huge part. We want to keep the diet a 2-gram sodium diet because when we have sodium, we hold on to water. And we want to remember the DASH diet recommended by the American Heart Association. If you don't remember the DASH diet, you'd be wise to look it up. We want to caution them to limit processed meat and cheese, cereals, canned soup, processed foods. Teaching them how to read the label is incredibly important. And where to look for the sodium content and how much sodium, how to convert milligrams to grams. because we say that, you know, it's a 2-gram sodium diet, and oftentimes sodium is reported in milligrams. It is very rare that we need to restrict fluids anymore. They used to put them on a big fluid restriction, but usually as long as we can control the sodium intake and use diuretics, we're pretty good and don't have to restrict fluids, because that's very uncomfortable for people. Teaching. Okay, so discharge teaching is a huge part of what we do. There's so much that you can read in your text, a little bit more. I'm going to give you the top couple. According to the heart failure core measures, you teach your patients to report signs and symptoms of worsening or recurring heart failure. What are they? Weight. An increase in 3 pounds over 1 week, or 1 to 2 pounds overnight. Report a decrease in exercise tolerance lasting 2 to 3 days. Report a cold or a cough that lasts more than 3 to 5 days. Report needing to wake up in the night to urinate. Report dyspnea or angina at rest or worsening angina. And report an increased swelling of the feet, ankles, or hands. Some possible nursing diagnosis, even I'm putting them on here because you'll see them and that helps you. There are no nursing diagnoses left on the NCLEX exam. It is only the concepts. So the major concepts that we looked at today is decreased cardiac output, decreased tissue perfusion, fluid volume excess, activity intolerances, anxiety, and knowledge deficit. They're the main concepts that we talked about today. Very, very important. How do you know if your treatment was effective? You'll know your treatment has been effective when the weight is down, the blood pressure is down, the O2 sat is good, urinary output is greater than 30 an hour, their skin is warm and dry, their lungs are clear, they're able to tolerate activities, and they're knowledgeable about the disease process and management of the disease. When students graduate, we are concerned with young nurses about something called failure to rescue. And so the main things from this lesson that you keep in mind so that you're not a nurse who fails to rescue, you remember that weight and blood pressure are a much better indicator of heart failure or pulmonary edema than is edema. Edema is an unreliable sign of heart failure. Daily weight coupled with blood pressure is the best indicator of fluid gain or loss. You remember that you need to provide enough oxygen to maintain an O2 sat greater than 90. Put them in high Fowlers. Put pillows under their arms. If their feet can dangle, let their feet dangle. Reposition them often. Do coughing and deep breathing. We want to prevent atelectasis. Get respiratory therapy involved if that's something that you have available to you. If you cannot maintain an O2 sat, you may need to go to CPAP, BiPAP intubation. Thank you very much. I appreciate your time. We'll talk more about this in class.